Respected VC Dr. Chakrati sir, Dr. Kapoor sir, Ravi sir, our chairperson for today's PGCR, Dr. Suresh Kulwal and Dr. Ashish Jain. To master the basics for the academic years is the theme for our PGCRs. And in the series of these PGCRs on different fundamental topics for our PGs, today we are going to start the fourth PGCR in this series, which is on dyspnea. And now I'd like to invite Dr. Mohit, who is the mentor for this PG.
Good morning, respected teachers, seniors, juniors, and colleagues. Today we are here to discuss the dyspnea. So why dyspnea is important to all of us, especially postgraduate students. If we see the prevalence of dyspnea in every setting, 30% of the patients who comes to the emergency, they have complaints of the dyspnea. While in ambulatory settings, every fourth patient is having complaint of dyspnea. If we see the different age groups, in adult population it is around 10%. But while in geriatric and middle-aged persons, it is going up to 60%.
To discuss and dyspnea about each and every aspect of every department. So to call, first we start with the physiology of dyspnea from Department of Physiology, Dr. Pragya Jain. From Department of Emergency Medicine, we have Dr. Nikhil to discuss the approach of dyspnea in critical emergency. To discuss the respiratory aspect of dyspnea, we have Dr. Bhavya Mehta. To discuss the cardiological aspect, we have Dr. Sweta. And for discuss the non-cardiac and non-respiratory cause of dyspnea, we have Dr. Gunita. And in last, the critical care manager of the dyspnea is covering by Dr. Mohit Somani. So I would like to call Dr. Pragya Jain to cover the physiology of dyspnea.
Thank you, sir. Good morning, all esteemed dignitaries, respected teachers and fellow students. Today I will discuss physiology of dyspnea from behalf of Department of Physiology. According to American Thoracic Society, dyspnea is a term used to characterize the subjective experience of breathing discomfort that comprises qualitatively distinct sensations that vary in intensity. And some other explanation of dyspnea in patients' word are, it is an uncomfortable sensation of difficult and labored breathing, a subjective awareness of one's own breathing, and a sensation of running out of air. These are the different types of dyspnea. First is orthopnea. In this condition, dyspnea occurs in recumbent position, as you can see in the picture, and it occurs in congestive heart failure and severe asthma. Second is platypnea. In this condition, dyspnea is induced by assuming upright position, and patients is relieved in recumbent position. It occurs in hepatopulmonary syndrome. Third is trypopnea. In this condition, dyspnea occurs when the affected side of the chest is in dependent position. Example is massive pleural effusion. And fourth one is paroxysmal nocturnal dyspnea. In this condition, patient is aroused from sleep. He has sensation of gasping and choking, and when he sits up, he gets relieved. It occurs in chronic obstructive pulmonary disease and heart failure. Now, normal breathing mechanism is controlled by central nervous system that has respiratory centers, mechanoreceptors or stretch receptors, and chemoreceptors. There are two types of respiratory centers. One is medullary center that has dorsal respiratory group of neurons and ventral respiratory group of neurons. This dorsal respiratory group of neurons are active during quiet inspiration, and ventral respiratory group of neurons are active during forced inspiration and expiration. There are two pontine centers. One is apneustic center that has control on intensity of respiration, and the other one is pneumotaxic center that has inhibitory effect on this apneustic center. So in all, they combinedly control the rate and rhythm of respiration, and they receive efferent mainly from the glossopharyngeal nerve and vagus nerve. Now, mechano-stretch receptors are present in the different part of the body. Like irritant receptors are present in the trachea and bronchus, and they are stimulated by foreign body. J receptors are present in the interstitial space, Proprioceptors are present in the muscles and joints, and stretch receptors are present in the walls of the bronchioles that are stimulated by hyperinflation of the lung, and a reflex occurs that is known as Herring-Brewer reflex of inflation. There are two types of chemoreceptors, central and peripheral. Central chemoreceptors are situated in the medulla, and peripheral chemoreceptors are situated in the aortic body and carotid body. These central chemoreceptors are very much sensitive for the H+ ion concentration that is primarily affected by CO2 levels, and peripheral chemoreceptors are stimulated by hypoxia, hypercapnia and acidosis. Now these are the causes of dyspnea. First is physiological, that occurs during pregnancy, anxiety, high altitude, and it can be exercise induced. And pathological causes are again classified on the basis of systemic involvement, that is respiratory causes, cardiac causes and non-cardiac, non-respiratory causes. And on the basis of duration of symptom, it is further categorized into acute and chronic. Now to discuss the acute causes of dyspnea, I would like to invite Dr. Nikhil from Department of Emergency Medicine. Thank you.
Good morning. Today we will be discussing about approach to dyspnea in emergency room. Acute dyspnea is represent one of the most common presenting symptoms in emergency room, and it needs an intense evaluation for that. Pulmonary causes, that is 35 to 40%, followed by cardiac causes 20 to 25% and others, and acute exacerbation of asthma and COPD and acute decompensated heart failure and acute coronary syndrome are the most common causes for both pulmonary and cardiac causes in dyspnea. We'll proceed to initial evaluation of dyspnea in emergency department. First, we will do the primary survey, that is, we'll look for the airway, breathing, circulation, disability and exposure of the patient. We have certain point of care biomarkers available, such as blood gas, cardiac markers, D-dimer and other hematological profiles. And for imaging part, we use chest X-rays, point of care ultrasound and chest CTs with or without contrast if needed. Approach to dyspnea in emergency department. First, we'll go for the ABCs. In ABCs, we assess the severity. We'll see whether the patient is unable to speak or is there any additional sounds are present, such as stridor or hoarseness. Any signs of respiratory distress is present. Any signs of increased work of breathing is present. If patient is having hypoxia or hypotension, and is there a marked decreased level of consciousness, attach the patient to the monitor, we'll start supplement oxygenation and assess and have an IV access secure. We'll assess we'll proceed with advanced airways or any surgical airways is required, and of course cervical spine stabilization in case of complications. There are certain to save the life, and we'll discussing those critical reversible causes. First is airway obstruction. If patient present with choking, or if there is any mucus plug or secretions, vomitus or foreign body present in the oral cavity, or patient is having stridor or difficult swallowing or drooling from mouth is present, then we will proceed with either Heimlich maneuver for the choking part, and if suctioning or forceps are required to remove the foreign body in the oral cavity, or if there is any need for definitive airway is required, we'll proceed with that. This is the depiction of Heimlich maneuver. The other critical reversible causes tension pneumothorax. In this X-ray, we can appreciate there is a right side pneumothorax towards the contralateral side. Present with absent sounds. There are marked distension, hypotension, and deviated trachea. And history of trauma, either spontaneous pneumothorax or iatrogenic tension pneumothorax can be there after intervention. The treatment part is needle decompression and chest tube placement. This is the X-ray of the same patient after placing the chest tube, and we can see the mediastinum has come to the normal place. The third and last critical reversible cause which we'll be discussing is anaphylaxis. There is a history of suspected or known allergen exposure is present, and patient present with hypertension hypertension, angioedema, wheezing or stridor is present, urticaria and other dermatological symptoms are present such as rashes, diarrhea, vomiting, in GI symptoms, and airways are compromised with the angioedema. We can see the patient with the oral mouth swelling and tongue swelling. The treatment part we proceed with epinephrine and bronchodilators, antihistamines, steroids and intubation if required. After discussing the critical reversible causes, the next task for us is diagnose the patient and find the cause for the dyspnea in ER, and for that we have point of care ultrasound. In the recent decades it has large boom in diagnosing dyspnea. In lung part we see for the A profile, in normal lung we see the A profile, and B profile with pleural thickening or shed sign suggestive of pneumonia. In pneumothorax we have barcode signs or absent lung point, and in pleural effusion we have jellyfish sign. After proceeding with lung ultrasound, we do the cardiac ultrasound, in which we can find plethoric ivs or RA-RV dilated, along with venous Doppler. There are clots present in popliteal vein or femoral vein. We can appreciate that it is a diagnosis of pulmonary embolism, and we look for pericardial effusion if there is a diagnosis for pericardial tamponade. Now I would like to invite my colleague Dr. Bhavya Mehta to discuss the respiratory causes of dyspnea.
Yes. So, spontaneous pneumothorax is the most critical emergency, isn't it? Which requires immediate attention. So, tell little more about how to suspect it and how and where to put that needle, because you don't have time to get a chest tube arranged. The treatment of spontaneous pneumothorax is put in a needle. Explain that.
Sir, spontaneous pneumothorax can be because of large number of diseases. In most commonly it is in COPD.
Don't go into theory, practical.
Okay.
Patient comes with dyspnea. When do you suspect that it could be spontaneous pneumothoracx?
Before
tension pneumothorax.
Before clinical examination of tension pneumothorax.
Okay.
Yeah,
Sir, the patient might be present with air hunger. He looks in great dyspnea. He is hungry for the air. On monitors we will have hypotension, hemodynamic instability, and on inspection part there are tracheal deviations, and on percussion we have hyperresonant, and there are absent breath sounds. And in adult basically there are patient needs emergent needle decompression for tension pneumothorax, and there are two sites for that. Mostly now it is recommended 4th to 5th intercostal space between mid and anterior axillary line, and we proceed with the needle decompression in that triangle of safety that is having. We have
5th or 2nd?
Sir, initially when we learned it was second intercostal space, but now it has changed to 4th and 5th.
For kids, for pediatric patient.
You missed, that is
Angos raised.
The other is an observation for all heads and faculty members. From now onwards, I would expect that the images shown belong to us, not from textbook or journals. I mean, we have such large clinical material. Why should we be showing images from textbooks? We should have our own images. So please make an effort, all faculty members, whenever a patient comes, you see a usual, unusual, rare, common, uncommon finding. Make sure that we have an image bank, and in a year from now, all presentations must have images from our own patients.
Okay.
Can you give us one reason to put an NIV in acute dyspnea in emergency?
So flash pulmonary edema, patient present with sympathetic overdrive, patient sometimes present with sympathetic overdrive. They have bilateral infiltrates and they are hungry for air. For that we need an NIV.
Type 1 indication.
Sir, obstructive sleep apnea, patient present with CO2 narcosis.
Type 1 indication for putting in NIV in acute dyspnea.
Type 1 indication, patient is conscious and tolerating.
Congestive heart failure.
What is that?
Congestive heart failure.
Congestive heart failure.
Acute. And the last question is, you showed us A profile, B profile, and different things. Can you give me the name of it?
Blue protocol way for the.
What is the full form of it?
Good morning everyone. Today I will discuss the assessment of dyspnea in pulmonary diseases. First of all, pathophysiology of dyspnea in pulmonary diseases. And the dyspnea is the mechanism of dyspnea basically can be divided into the two parts, obstructive causes and restrictive causes. In obstructive causes, there is increase in airflow resistance in the bronchi, which leads to the hyperinflation of thorax, ultimately leads to increased work of breathing, and it leads to dyspnea. Examples are asthma, COPD, bronchiectasis, etc. The second is restrictive causes. In restrictive causes, there is a compliance and total lung capacity is reduced, and which leads to stiffening of the lung. Examples are interstitial lung disease, pulmonary edema, fibrothorax, kyphoscoliosis, etc. Now, common pulmonary causes of dyspnea. When the disease affecting the airway, like asthma, COPD, bronchiectasis, then the disease affecting parenchyma. In alveoli, there can be pneumonia, ARDS. In interstitium, there can be interstitial lung disease, pulmonary edema. There can be diseases like pulmonary embolism, pulmonary hypertension, pleural abnormalities like pleural effusion, pneumothorax, and chest wall abnormalities like kyphoscoliosis and neuromuscular diseases. Issue of bronchial asthma, cystic fibrosis, alpha-1 antitrypsin deficiency, which are having genetic risk factors. Then we should ask about the cigarette smoking. It increases the risk of carcinoma lung, COPD, then exposure to silica, coal, hair, which can lead to the pneumoconiosis and hypersensitivity diseases. Then after the history, we will examine the patient. First of all, general examination. Diagnosis. Dyspnea associated with clubbing is commonly seen in carcinoma, bronchiectasis, lung fibrosis, empyema. There can be lymphadenopathy in cases, it can be suggestive of underlying malignancy. Then we will go to the respiratory system examination. We will do the inspection and palpation. First of all, we will see the shape of the chest. If it is barrel-shaped chest, commonly seen in the COPD patients. Then the respiratory rate, increased in respiratory distress, pleural inflammation, anoxemia. It is decreased in CNS depression like narcotic poisoning, brain tumors. And the respiratory rhythm. The chain stroke respiration is commonly seen in congestive heart failure. Then Kussmaul respiration is commonly seen in diabetic ketoacidosis, Biot's respiration, apneustic respiration. Then we will see the movement of the chest. If it is unilateral, it is commonly seen in pneumothorax pleural effusion patients, and bilateral diminished movement is seen in the patients of COPD, asthma, and bilateral lung affecting diseases. Then trachea and apex beat, if it is opposite side shifted, commonly seen in pneumothorax and pleural effusion, and same side shifting is seen in the lung collapse and fibrosis patients. Then tactile vocal phlegmitis, it is the tactile perception of lung parenchyma during phonation. It is increased in consolidation and lung mass. Then we'll do the percussion of the chest. The normal lung have the resonant note. If it is dull note, it is seen in the consolidation and lung fibrosis. Stony dull note is particularly heard in cases of pleural effusion, and hyperresonant note is heard when there is increased air like pneumothorax, emphysema, cavity. Then we will do the auscultation of the chest. Normal lung produces the vesicular breathing, which we can hear. When there is bronchial breathing is present, it is suggestive of underlying cavity, open pneumothorax. There can be the added sounds like crepitations, which we can hear. It is commonly found in pneumonia, bronchiectasis, fibrosis, pulmonary edema. There can be the rhonchi, which is suggestive of narrowing of the airway, seen in COPD, asthma, malignancy patients. There can be stridor, which is suggestive of upper respiratory tract obstruction, and there can be pleural friction rub, which is suggestive of pleural inflammation. Then we will further assess the dyspnea by doing the investigations like chest X-ray. Here we have included some common findings. The first chest X-ray, we can see the hyperinflation of the lung, the tubular heart, flattening of diaphragm, commonly seen in COPD cases. Then the second chest X-ray, we can see the consolidation in affecting the right lower zone with right diaphragm seal out. It was the case of right lower lobe pneumonia. Then in the third chest X-ray, we can see the right shipping ankle blunting meniscus sign, which was the right pleural effusion. And in the fourth chest X-ray, we can see the right lung mass affecting right upper and middle zone. It was the case of lung malignancy. Then we can further assess the dyspnea by the spirometry. In the spirometry, we will first see the FEV1 FVC ratio. If it is less than 0.7, it is seen in the it is suggestive of obstructive defect like COPD, asthma, and bronchiectasis. If ratio is more than 0.7 and FVC less than 80%, it is suggestive of restrictive defects like interstitial lung disease, pulmonary edema, fibrothorax. Now we'll cover the the management of the common causes of dyspnea. The first is COPD and asthma, managed by bronchodilators, inhaled systemic corticosteroids, and mucolytics. The pneumonia is managed by antibiotics and ventilatory support. The bronchiectasis we give, it is treated by the antibiotics, bronchodilators, anti-inflammatory treatment like inhaled corticosteroid, chest percussion, and postural drainage. Pneumothorax managed by tube thoracentesis, and when in cases of tension pneumothorax as covered by Dr. Nikhil, it can be the needle thoracentesis can be done. And for pulmonary embolism, it is treated by anticoagulants or thrombolytics with oxygen therapy and ventilatory support. Now, as we have covered the dyspnea in pulmonary diseases, I would like to invite Dr. Sweta Patel to cover the dyspnea in cardiology disease.
Good morning, everyone. Now I will discuss dyspnea in cardiology. The features in dyspnea suggesting mainly cardiac causes are paroxysmal nocturnal dyspnea, orthopnea, angina pectoris, anginal equivalent. Patients comes with shortness of breath, having coronary artery disease, which is termed as anginal equivalent. Expectoration of pink frothy sputum seen in pulmonary edema. Keinstroke breathing. It is a cyclical fluctuation of hypopnea or apnea followed by hyperpnea. Rapid progression of symptoms. Little or no cyanosis with severe dyspnea. Response to diuretics and digoxin. Evidence of any heart disease by physical examination and investigation. The basic main cardiac causes which are leading to dyspnea are: number 1 is coronary artery disease, valvular heart disease, that is mitral stenosis, regurgitation, aortic stenosis, aortic regurgitation, pulmonary embolism, arrhythmia, cardiomyopathies, cardiac tamponade. This all the causes which I told earlier leads to dyspnea mainly due to left heart failure, as well as in some condition it also leads to dyspnea occurs due to right heart failure also. Left heart failure mainly leads to pulmonary venous congestion and decrease in the stroke volume. This leads to transudation of fluids into the alveoli and interstitium, which leads to increased airway resistance, hypoxemia, J receptor stimulation causing dyspnea, and decrease in the stroke volume, that is due to left heart failure, leads to end organ hyperperfusion, leading to fatigue, cyanosis, cold extremities, renal dysfunction, and confusion. In some conditions, right heart failure also occurs, mainly in pulmonary embolism. There is increase in the pulmonary arterial pressure, which leads to RA-RV dilatation, leading to decreased RV output. This in turn leads to decrease in LV preload and LV output, leading to decreased systemic perfusion. We in cardiology classify dyspnea on the basis of New York Heart Association classification. A patient with structural heart disease have been classified into 4 classes. Class 1, there is no symptoms or limitations in ordinary physical activity. In class 2, mild symptoms developed during ordinary physical activity. Class 3 is marked limitations to ordinary physical activity. And class 4, there is severe limitation, patients develop dyspnea at rest. Now, how we evaluate the patients coming to us with dyspnea? We first of all we try to rule out the conditions which we discussed earlier, like coronary artery disease, valvular, cardiomyopathies, cardiac tamponade. We look for the ECG. The ECG showing in anterior wall MI, there will be an ST elevations in anterior leads, V1 to V3. In inferior wall MI, there is ST elevation in inferior leads 2-3 AVF. In the arrhythmias, there is a ventricular tachycardia, wide broad complex QRS will be present. In atrial fibrillation, there is irregular rhythm. The fourth ECG, the next ECG is suggestive of a low voltage ECG, that is pericardial effusion, which we see. Pericarditis, there is a concave ST elevation seen in all leads. Secondly, we go for echocardiogram. In echocardiogram, in mitral stenosis, we look for this is a plex view, in which we see there is a posterior mitral leaflet, fixed posterior mitral leaflet with voxic appearance of the anterior mitral leaflet with LA enlargement. Color Doppler is suggestive of mitral regurgitation. Thick calcified mitral valve. In aortic regurgitation is seen with the help of color Doppler. We look for the pulmonary gradient. In pulmonary embolism, the RV dilated, IVC less collapsing. There is decrease in the RV wall. There is RV wall dysfunction. In cardiac tamponade, there is a fluid accumulated. Patient comes with severe dyspnea, and there is decreased feeling of the cardiac chambers. Now, general management. In coronary artery disease, we go for the thrombolytic. If patients comes in window period, we go for the thrombolytic therapy, injection streptokinase or BT, antiplatelet, anti-anginal therapy, and then we proceed for then percutaneous coronary intervention. We go for in anemia patient is hemodynamic. For mitral stenosis, balloon mitral valvotomy, or may go for valvular replacement. In pulmonary embolism, which we go for anticoagulants, thrombolytic therapy, oxygen therapy and ventilation. And in cardiac tamponade, needle pericardiocentesis, pericardial drain placement is done, pericardiocentesis. Now we'll discuss the non-cardiac and non-pulmonary causes by Dr. Gunita Sharma.
Namaskar everyone. I'll be talking about the non-cardiac and non-pulmonary causes of dyspnea under 4 headings, that is acidosis, mechanical causes, psychogenic causes and neuromuscular causes. First condition causing acidosis is sepsis. What happens in sepsis is due to alteration in the cellular metabolism, our body turns towards anaerobic metabolism, leading to formation of lactic acidosis, which leads to metabolic acidosis. To counteract that acidosis, patient hyperventilates, which may be presented by the patient in varying degree of dyspnea. Treatment is the source of sepsis, also supportive and symptomatic treatment. Diabetic ketoacidosis, this is a state of absolute insulopenia and a hallmark complication of type 1 diabetes, also seen in type 2 diabetes due to non-compliance to the medication. Ketones build up faster in the body because there is absolute insulinopenia. There is glucose everywhere, but our body cannot use it, so it turns to fatty acids for metabolism, for the energy. So ketones build up faster than the kidneys can remove it, which are toxic to the body, and our body tries to expel it by a very classical breathing, which is seen in these patients, that is Cosmol breathing, that is rapid and deep breathing. The treatment is fluid replacement and insulin therapy. Toxins leading to dyspnea are salicylates and organophosphorus poisoning. Salicylates is majorly aspirin we see. Direct stimulation of medulla, salicylate poisoning leads to direct stimulation of medulla, which leads to hyperventilation, respiratory alkalosis. Also, it is an electron transport chain uncoupler. So ATP is not produced by that pathway, and again it goes to anaerobic metabolism, leading to metabolic acidosis, leading to respiratory alkalosis. Treatment is prevent the further absorption of the toxin by activated charcoal, IV fluids, and alkalinization of urine by soda bicarb. Organophosphorus poisoning, it is an acetylcholine esterase inhibitor. So there is increased acetylcholine in the body, which acts on nicotinic and muscarinic receptors. Initial 1 to 2 days are muscarinic effects, which causes bronchospasm and increased bronchial secretion, which leads to dyspnea. The very classical signs and symptoms seen in organophosphorus are remembered by us by the mnemonic dumbbells. Treatment is IV atropine and oxins. Anemia usually leads to dyspnea on exertion. Decreased availability of RBC for conjugation with oxygen leads to decreased availability to the muscles, which leads to dyspnea. Treating the underlying cause of anemia and blood transfusion is the treatment of choice for anemia. Anxiety. Stress leads to direct stimulation of medullary chemoreceptors, which leads to hyperventilation. The catastrophic misinterpretation of these symptoms leads to dyspnea. Treatment is psychiatric evaluation, anxiolytic agents, therapy, and breathing technique. The classic paper bag rebreathing technique, which introduces carbon dioxide back into the body, which has been flushed out during the stress. Mechanical causes we are going to talk about are obesity and pregnancy. During active labor, pain and anxiety causes hyperventilation and tachypnea, while during pregnancy, the diaphragm is displaced upwards by 4 cm, which leads to progressive decrease in functional residual capacity. Also, high progesterone in pregnancy causes increased alveolar ventilation, leading to dyspnea and respiratory alkalosis. Mechanical causes also includes obesity. Morbid obesity is more than 40 kg per meter square. Mechanical compression of the diaphragm and lungs and chest cavity leads to reduced chest wall compliance. Excess fat also reduces total respiratory system compliance, increases pulmonary resistance, and reduces muscle strength. Mechanical causes also includes hepatopulmonary syndrome and ascites. Nitric oxide released from the cirrhotic livers causes vasodilation. Usually in our lungs, under stress, vasoconstriction occurs, but in hepatopulmonary syndrome, vasodilation occurs, leading to AV shunting and VQ mismatch, which leads to hypoxia and dyspnea. Treatment is oxygen support and liver transplant. Hepatopulmonary syndrome is the indication for liver transplant. Ascites, large volume of fluid pushes the diaphragm upwards, compresses the lower lungs, atelectasis, and which leads to dyspnea. Paracentesis is the treatment of choice. Neuromuscular disorders are multiple sclerosis, which is a chronic demyelinating disorder, amyotrophic lateral sclerosis, and polio, which is in which the anterior horn cells affected. Therefore, it leads to muscle weakness. Iatrogenic trauma is seen in cardiothoracic surgeries, in which the phrenic nerve is affected, leading to diaphragmatic paralysis. Guillain-Barré syndrome is peripheral nerves are affected. It is a demyelinating polyradicular neuropathy. All these disorders leads to restriction in the movement of respiratory muscles and diaphragm. Therefore, chest compliance is decreased, and therefore it leads to dyspnea. Treatment is ventilatory support and an IV support. Now, I'd like to call upon Dr. Mohit Somani from critical care to talk about the critical care treatment.
As we have already discussed about approach to acute and chronic dyspnea in previous presentations, now I will discuss about its management according to critical care medicine. In critical care, our approach to dyspnea entails a dual focus: immediate intervention to alleviate respiratory distress, and coupled with meticulous investigation and treatment to underlying etiology. Simultaneously engaging in assessment, evaluation, and targeted intervention form the cornerstone of our strategy, which enables swift and comprehensive management of dyspnea. As it's been already discussed by Dr. Nikhil, we assess patient as per ABCDE protocol, where A denotes for patency of airway to maintain the oxygenation, B for breathing, C for circulation, D for disability and deformities, E for exposure and examination. As our first priority is airway and oxygenation, these are the different modalities to deliver the patient oxygenation to the patient of dyspnea. These are of two types. Low flow modalities include nasal cannula and facial mask. High flow modalities include Venturi mask and non-rebreathing mask. High flow nasal cannula delivers high flow rates, achieving a higher FiO2 with greater patient comfort. Non-invasive ventilation is used to improve oxygenation and ventilation. It reduces work of breathing and prevent intubation. These are of two types. CPAP improves oxygenation and BiPAP improves oxygenation and ventilation both. Indications are COPD with type 2 respiratory failure, neuromuscular disease with respiratory failure, obesity with obstructive sleep apnea with respiratory failure. Contraindications are severe facial deformities and cognitive impairment. When any of the modalities is not working for the patient, then we should go for invasive ventilations. Indications for same are airway protection for poor mental status or inability to handle secretion, failure of non-invasive therapy, for ineligibility for non-invasive therapy, or increased work of breathing despite non-invasive therapy. For severity of ARDS, if there is rapid progression or persistent hypoxia or persistent hypercapnia, or if there is hemodynamic compromise like cardiopulmonary arrest or hemodynamic instability. To prevent unanticipated difficult intubation, we keep ready difficult airway trolley. Thank you.
Yeah, all of you have presented very nicely, and you have covered the subject. And just I'll summarize it. The causes of dyspnea, as you already have mentioned, all these causes: cardiac causes, pulmonary causes, and extra causes like non-cardiac, non-pulmonary causes. Now, to diagnose the dyspnea, the clinical history is very important. When you put the patient on oxygen, you put the patient on oxygen monitoring and cardiac monitoring, and you can take the history with the attendant and the patient's relative. You can take the history whether patient is already going on any treatment. Most of the patient, with the looking at the prescription of the patient, you will find out what is going on. If the patient was hypertensive or diabetes, patient was known case of COPD, or patient was known case of asthma. So ascertain the ongoing illness. Onset, some diseases are acute in onset, like pulmonary embolism, acute myocardial infarction, and pneumothorax. They are acute in origin. Subacute means within hours to days, and chronic is 4 to 8 weeks at least. Patient is have dyspneic. These are the chronic, like COPD is a chronic disease. Now, time of the day, whether it is nocturnal or whether it is at the rest or whether it is on the exertion. Now, body position, orthopnea, platypnea, tapopnea, which position. So all these give suspicious of what disease patient is having. Episodic, like in asthma, progressive, like in COPD. Age of the patient. If the child is there, you will not suspect a patient of cardiac, least likely, or patient of COPD is not there in child. You will suspect either patient is having bronchiolitis or foreign body aspiration. If the patient is adult, you will suspect of pneumonia or bronchial asthma. If the elderly patient is there, first suspect. If the patient has no history of respiratory disease, always suspect cardiac cause. Acute left ventricular failure, acute MI, or malignant hypertension, or patient has developed arrhythmia, or patient has ruptured cardiotendinae. So these 4 causes you will always suspect in the patient who is presenting. If that does not have any previous history, elderly patient. And comorbidity, what are the associated condition with the patient, will most of the time tell you the cause of dyspnea. Now, how to evaluate the patient? He takes the history and physical examination, which is still most important in diagnosis. And if the diagnosis is possible diagnosis is asthma, COPD, pleural effusion, congestive cardiac failure, and even kyphoscoliosis, and 2 more investigations, basic investigation, X-ray chest and ECG you will do. So if the X-ray chest will tell you what is the problem, whether it is cardiac problem or whether it is respiratory problem, ECG will also tell the problem whether it is pulmonary or non-pulmonary or non-cardiopulmonary. If the X-ray and ECG is normal, go for the spirometry. And do the hematocrit also. If the hematocrit is less than 35, look for the anemia. If it is more than 35, then go for the another investigations. And the level 2 testing. In the level 2 testing, you will find the pericardial disease, congestive cardiac failure, valvular heart disease, cardiac arrhythmia, restrictive lung disease, interstitial lung disease. Here you will go for the echocardiogram or lung ultrasound. Both, though these are non-invasive investigations, you can go for that. If the patient is, you are suspecting clinical suspicion of pulmonary embolism is there, you go for the D-dimer. D-dimer is very sensitive but less specific. If the D-dimer is normal, it rules out pulmonary embolism. If the D-dimer is high, go for the CTPA or higher HRCT. Or if the patient is suspecting patient has developed arrhythmias, then you can go for the Holter monitoring. ABG is not an important for diagnosis of dyspnea, what cause of the dyspnea. ABG is important in the management of the dyspnea. So the level 3 testing, if you are not reached to the diagnosis, you go for cardiac catheterization, you go for the cardiopulmonary exercise testing, bronchoscopy, esophageal pH, or lung biopsy if the pathology is lung pathology. So if everything is normal, you consider psychogenic dyspnea. Now, this is a case, 35-year-old male admitted with a history of shortness of breath for 7 days, fever 7 days, cough expectoration for 7 days, chest pain. On examination, their oxygen saturation is 87% on room air, pulse 104, BP 140/80, respiratory rate 19 per minute, and right-sided crackles. This is the X-ray of the patient. What is the diagnosis? Pneumonia. Okay. So, a 29-year-old patient complains of breathlessness, evening rise of fever, cough, chest pain. There is stony dull note on the right side of the chest and air entry is absent on the right side of chest. This is the X-ray. What is the diagnosis? Massive pleural effusion. Okay. Now, this 75-year-old male chronic smoker admitted with complaints of difficulty in breathlessness and cough and expectoration, respiratory distress with prominent use of accessory muscles, prolonged expiratory phase with bilateral bronchi. This is the X-ray. What is your diagnosis? COPD. Now, 76-year-old male patient complains of acute dyspnea and chest pain, BP 95/72, hemoglobin 13.8 grams, SpO2 70%, patient has lactic acidosis, patient is known case of hypertension and diabetes mellitus. This is the ECG and X-ray. What is the diagnosis? This is the echo and angiography, and it was found to be acute left heart failure with cardiogenic shock. A 52-year-old female with acute dyspnea and chest pain, BP 115/85 mm mercury, tachypnea, patient has SpO2 56%, respiratory alkalosis, D dimer is 2800. This is the CT scan and this is the ECG. S1Q3 pattern, and there is thrombus in the bilateral arteries. And pulmonary artery pressure is 60 mm mercury. So this is a pulmonary embolism. Thank you very much.